Hello, Dan. Thank you very much for accepting to answer a few questions today. So this is Dr. Dan Wiseman, who is from the Christie Hospital in Manchester. So we are today at the UK MDS Forum Education Day, and you've just been giving a talk about the understanding of the biology and treatment of CMML. Can you just, in a few words, summarize what you have presented today?
Sure. So my interest is in CMML, which is a rare subtype of myelodysplasia, but that also has features of myeloproliferation or myeloproliferative disorders. So what does that mean? It really means that these patients have kind of the worst of both worlds, in that they have bone marrow stem cells that don't make blood effectively, so they get bone marrow failure, the blood counts are low, they're anemic, they can often have low platelet counts and bleeding problems and infection risk, much like other myelodysplasia patients, but they also have a part of their disease that's making the white blood cell count go too high, or what we call myeloproliferation. And these two things converge to cause a really difficult disease to treat. And it's a disease that's really slipped through the cracks a lot over the years. It's been considered a subtype of MDS. More recently, it's been recognised that it has its own unique features and things that it can tell us about blood cancers in general, and is now recognised as its own separate disease entity. And whilst our treatments at the moment for it are unfortunately some way off where we like them to be, there's an awful lot of work going on around the world in the labs to try and understand this disease better. And much of this is leading on to finding new ways of targeting this disease. And there's a lot of targeted therapies that are in trials at the moment that could be useful here. And so what my talk was doing really was trying to give a whistle-stop tour through where we are up to in terms of understanding what causes this disease, what causes it to develop onto more aggressive acute leukemia, and trying to sort of weave that in with some of the new therapeutics that are being tested. It's currently in early phase trials, because I do believe we're probably on the verge of hopefully an explosion of new treatments for this disease.
Okay, thank you very much. So tell us a little bit more about specifically the talk you gave.
Yeah, sure. I mean, it was an overview of quite a lot of biology, but really focusing on what we know about the mutations or faults in different genes that cause CMML. There's not very many of them, which helps us hone the search, and really discussing the ways that we understand how some of these mutations behave and ways in which we can manipulate them to develop treatments. So, for example, there's two classes of these mutations that are really frequent in patients with CMML. One class of mutations are what we call epigenetic regulators, or epigenetic mutations. And these genes are there to really control how genes are switched on and off around the body, and they have loads of roles. But it's a way of getting more out of your DNA blueprint than what's actually just written down. There's one particular epigenetic gene called TET2, and people have faults in this gene with all sorts of blood cancers, but it's particularly common in people with CMML. And what this leads to is effectively too much of something called methylation around the genome. And there's a lot we still don't understand about this, but what it does is it switches off certain genes, and we know that this is important in how CMML develops. So the standard treatments at the moment are drugs like azacitidine, which is what we call a hypomethylating agent, and it really works by just taking this methylation off all around the genome. And we know from experience that this is very helpful in MDS more broadly, and also in some patients with CMML. So I spoke a little bit about some new science that's out there to try to identify beforehand which patients are most likely to benefit, because we know that this drug isn't as good as we'd like it to be. Only probably around 20 to 30% of patients will get really good responses to this drug. Maybe 50% will get some response. So about trying to target the existing therapies better to who's most going to benefit from them. And there's been a lot of work looking at different mutation profiles and looking at the expression of different genes and the patterns of this methylation across the whole genome. And lots of big data sets are just starting to give us a feel for who might respond better to the existing drugs. But I think where there's even more excitement is on the next generation of these drugs. And I spoke a little bit about a drug called Guadacytopine, which is coming through trials. It's currently in a phase 3 study, and it's shown some good effects in a phase 2 in which CMML patients were represented. And I think it's unclear at this stage whether this is going to be an improvement upon where we are at the moment, but I think there's reason to think there might be. And on that part of the talk, I was particularly interested to talk about an even newer drug, which is a tablet version, because at the moment all of these hypomethylating agents have to be given as injection. And generally these involve very frequent visits to the hospital, and it's a huge burden on patients. It's not even an injection that in most places people can take home and do themselves, just because of the stability. It needs to be made up on the day in the hospital. So, typically patients are going for 7 consecutive days or 7 consecutive weekdays in most centres. And it's a huge burden. Now, if you could get the same effect from a tablet, that would obviously be much better. And there's a couple of options. I spoke about one of them. That has been through trials and is showing good signal in CMML patients and seems to give the same effects as the versions that are injected either under the skin or into the vein. And so, we're hopeful. We're in the very early stages of trying to get a trial funded and set up to, for UK patients to access this drug.
Tell me what that drug is.
Yeah, so at the moment it's got a very fancy name of ASTX727. I'm sure it will get a more memorable name soon. And it's going to be the base of an international basket trial, which we call it, where it's going to be tested alongside 3 other, even newer drugs that are coming off the pipeline from a different drug company. And they're working together to offer these combinations to patients. And a really important thing about this study is that for the first time, it's going to allow other patients with similar diseases to CMML, but that aren't technically classified as CMML. And although those patients are fewer, I think it's really important because these patients until now have never had any trial options whatsoever. I mean, CMML has had a dearth of trials over the years itself, but these other patients whose disease resembles CMML but isn't exactly CMML have always had no options at all. So I think that's one innovative part of this international study. And another is that unusually patients are going to be allowed to move from one arm to another. So if you get drawn randomly to receive the ASTX727 and drug 1, if that doesn't work for you or doesn't suit you, then there would be an opportunity to move on to one of the other arms. And the trial will evolve over time as well as new drugs come off the pipeline. So it's a really exciting initiative. It's an international collaboration between people with an interest in these diseases. We in the UK are a little behind for various reasons. We're not going to be able to take part in this study. There's several other European countries and several centres in the US working on this. There is UK representation in the trial. Myself and some colleagues are members of subcommittees. And what we're hoping to do in the meantime is to develop our own clinical trial that would be helpful to the broader effort, which is just going to be using the ASTX727 on its own. And that will be useful. It will give an opportunity for UK patients to receive to receive this drug, and it will also build up information that if we think about it in advance and plan things correctly, then it can also inform the results of the broader international study. So I'm quite excited about that. I then went on to speak about a heap of other interesting experimental drugs that are further behind in development, I'd say, but ways of targeting other things like splicing, because we know that CMML patients have defects in splicing, which is a fundamental biological process where genes are kind of chopped up and rearranged, and it's normally very carefully controlled. But some of the proteins that do that develop faults in MDS and particularly in CMML. And so I discussed some of the ways in which we're designing drugs to try to directly treat that in a targeted way, and also interest in targeting other, we call signaling pathways, where proteins get switched on that then tell the cell to grow and divide. And there are a number of those that we know are too active in patients with CMML, and it's probably the main reason why CMML patients have this excess of white blood cells that it distinguishes them from other MDS patients. And it's often, if not always, because of activation of these pathways, and we know a lot about these pathways, and it's not an easy thing to target, and I think we're some way off having really cracked it, but there are now a growing number of novel therapies that are targeting different components on this pathway to hopefully sort of dampen down those signals. And one of them that is still in sort of pipeline phase and isn't ready for human trials yet, but our lab have got an agreement with the drug company to actually start testing it in CMML in the lab, which is different from, I think, the original area they were thinking of, and I'm really hopeful that might lead somewhere down the line ultimately to a clinical trial of that drug too.
Here at the UK MDS Forum Education Day meeting, and as well as Dr Dan Wiseman from the Christie Hospital in Manchester, we have Chris Dugmore, who's a MDS UK committee member and our local group coordinator for Essex. Chris Dugmore is also a CMML patient, and we took this opportunity to get Chris to ask Dan a few questions about CMML.
Thank you, Sophie. Yes, Dan, as you know, we've spoken about this. I've been a CMML patient for 11 years, which in itself is something of an unusual thing. But in that time, I have sort of noticed that so many of the features of CMML don't necessarily occur in other forms of MDS, and I wondered if you could talk just a little bit about those and what treatments might be available.
Sure. Yeah. No, it's a really great question, and it's an important point about CMML, and as I was discussing earlier about the sort of merging of symptoms of different disorders that you get in CMML, and so as well as the bone marrow failure, it is very common to get inflammatory type symptoms. So, weight loss, sometimes very extreme. The spleens get very enlarged, and again, that can happen in other MDS subtypes, but it's much less common and not usually to the same degree. And that can be very painful. It can make people feel full early. Even if it's just a nagging awareness of a swelling in the tummy, then when it's there all the time, it can have a huge impact on quality of life. Some CMML patients, just really because of how proliferative this disease is, it drains your energy. It can cause sweats and night sweats, and there are rare cases where you get inflammatory stimulation around the body that causes fluid build-ups. Yes. And I know this is something that we've discussed before. This is how
mine kicked off, going from fully healthy to two lungs full of fluid, and nobody, this was, say, 11 years ago, really seeming to understand why that was.
It is quite an unusual symptom to have to any significant degree. Quite often we'll see small amounts of fluid building up, but absolutely, I don't think there's any question that this will have been part of the disease. And there's still a lot we don't understand about some of these other features, but I think we are getting there. One other thing we discussed, I discussed in the talk, which was obviously heavily focused on the biology and how that's leading to new treatments. But there have been some big studies now, collaborative studies across the US and Europe, and some with ourselves in the UK, where we've, for example, looked at the levels of what's called cytokines, which are little proteins in the blood that are often released. In normal circumstances, they'll be released when your body's responding to an infection. They cause inflammation. Some of them make your temperature go up. That's why we get fevers. But we're starting to map and profile these in CMML patients, and we're seeing quite significant differences between CMML patients and healthy controls. And this is probably driving a lot of the symptoms. And importantly, in the lab at least, if we give treatments that reduce the levels of these cytokines, then we can see that is linked to the likelihood of response. And so some of the treatments that are being developed, and some of them are already being used in other conditions, like myelofibrosis is a good example, where a lot of these symptoms are similar. So some of the drugs that have been used in myelofibrosis are being tested in CMML. Ruxolitinib is one example.
I mean, I've heard of, sort of anecdotally, some very, very good responses to ruxolitinib in terms of spleen reduction. People going from a 21 centimetre spleen to non-palpable in 3 months. And for them, for their quality of life, it's made such a difference because they've been able to, eat, gain weight, have more energy, and so that drug has made sort of quite a difference.
So, I think a couple of comments on that. Absolutely, ruxolitinib was one of the drugs I discussed. The experience in CMML is limited. We've all got patients who have ended up being treated with it for one reason or another, but it's mostly used in other diseases, and that's what the importance, I think, of developing clinical trials that are targeted at CMML patients. And then you can design it that way, and you can build the data to show that it works, or if it doesn't, in that particular disease, because until that happens, it's very difficult to get access to these new drugs. At the moment, for understandable reasons, the NHS, through NICE, does have restrictions on who can receive these drugs, and ruxolitinib is a good example where a lot of patients with different but similar diseases, or diseases that share some features, are now almost as standard of care in some cases, receiving ruxolitinib and getting these really good benefits. And our feeling is that there would be a role in CMML. At the moment, outside of clinical trials, it's very difficult, and so I presented some data from the Padron group and a few centres in the US who have tried it in a phase 1 setting and seen some responses and characterised those. And there's a phase 2 ongoing at the moment, and there are other similar drugs that are being developed. Another drug I mentioned is a selective JAK1 inhibitor. Now, ruxolitinib works by targeting this protein called JAK. Well, we think of it as a JAK2 inhibitor, but it really hits both JAK1 and JAK2. And it may be that we'd get more effect if we just hit JAK1. I think there's a good reason to think that might be the case. And JAK2 might be causing some of the side effects that limit how much of the drug we can give. And so one of these drugs that is being developed has been designed to just target JAK1. We don't know yet if it's going to be any better, but I think it's important, and it's encouraging that all of a sudden we do have quite a lot of clinical trials coming through at least, and it's important that we in the UK make sure we get involved in this.
Well, as you say, so many of the trials that have been done have such a small number of CMML patients. Understandably, because the numbers for that subset are a lot smaller anyway, so it's difficult to get people to recruit people to trials. But nevertheless, it's sometimes very difficult, isn't it, to draw conclusions with such small numbers in these trials.
And yes, I mean, I gave the example in the talk of azacitidine, which was approved because of some seminal, enormous phase 3 studies in MDS. When you actually look at the number of CMML patients, there were 6 in one arm of the study and I think 5 in the other. Sometimes it works to your advantage because that was enough to get it approved in the UK, and it's certainly an important drug in CMML. It's the gold standard for many patients. But I'm sure we can do better, and it feels like that there are new exciting drugs on the horizon. And I think what's good, and I hope came across in the talk, is the way that understanding the biology is driving this development. Things like drug screens are useful, where you just take lots of chemicals, lots of drugs, and just test them in a high throughput way and see what works. But I think there's something to be said as well for rationally designing drugs because of your understanding of the disease. And I think that feels to me anyway like that's where we're up to with this disease.
Thank you very much.
Okay.
Thank you.
Thank you very much, Dan.
You're welcome.